community organizations, including public health, play in building trust within and across communities of color and culture. I now have the privilege of introducing today's speakers. First, we will hear from Michael Curry. Mr. Curry is President and CEO of Massachusetts League of Community Health Centers, which represents 50 health centers serving over 1 million patients over 300 practice sites. He brings over 35 years of experience and results in civil rights advocacy, health reform, and health equity. He is a current nationally elected member of the National NAACP Board of Directors and an immediate past president of the Boston branch of the NAACP. Attorney Curry is also an adjunct professor at both New England Law Boston, teaching diversity and inclusion in the legal profession, and Suffolk University's Moakley Center and Sawyer School of Management, teaching a healthcare management and policy course. Next, we'll hear from Trinidad Jackson. Dr. Jackson is an assistant dean for culture and liberation and is also an assistant professor at the University of Louisville School of Public Health and Information Sciences. Dr. Jackson has engaged in multiple fellowships with organizations focused on socio-political transformation, including Kentuckians for the Commonwealth and Be Me, an organization working to transform Black communities locally and nationally. Additionally, Dr. Jackson is a member of the Association of Schools and Programs of Public Health's Framing the Future expert panel on inclusive excellence through a racial equity lens, and is a board member for the Minority Mental Health Project. Third, we'll hear from Thea James. Dr. James is the Vice President of Mission, Associate Chief Medical Officer, and Co-Executive Director of the Health Equity Accelerator at Boston Medical Center. She is a professor of emergency medicine and director of the Violence Intervention Advocacy Program at BMC. Dr. James is a founding member of the Health Alliance for Violence Intervention. In 2011, she was appointed to Attorney General Eric Holder's National Task Force for Children Exposed to Violence. And finally, we will hear from Bisola Ajakutu. Dr. Ajakutu serves as the Executive Director of the Boston Public Health Commission and is a nationally recognized physician leader, health equity researcher, community advocate, and expert in prevention, care, and treatment of infectious diseases. She is a key advisor to Boston's mayor on health issues and builds innovative partnerships across city departments and within Boston's community to positively impact the health of all city residents. Among other public health priorities, she is committed to addressing racism as a public health crisis and advancing health equity. Dr. Ajakutu is an associate professor of medicine at Harvard Medical School, a faculty member within the Division of Global Health Equity at Brigham and Women's Hospital. She also holds an appointment within the Infectious Disease Division at Mass General Hospital as an adjunct faculty member at the Fenway Institute. Most recently, Dr. Ajakutu serves as director of the Community Engaged Research Program and the associate director of the Biobehavioral and Community Science Core for Harvard Center for AIDS Research. Thank to every one of you for joining this conversation. As a reminder for the audience, we will follow individual presentations. We will turn to moderated group discussion. When we have about 20 minutes left in the program, I will turn to audience questions. Please submit your questions using the Zoom Q&A function located at the bottom middle of your screen. Mr. Curry, I will now turn it over to you.
Thank you. Thank you. Honor and a pleasure to be with you this afternoon. To Dean Stein, to my good friend, Associate Dean Andrade, to the rest of the leadership at BU School of Public Health, Yvette, all the critical work that all of you do there to educate and prepare the next generation of leaders and diverse leaders. I want to say this to sort of tee off this call. Thank you for the critical work that you do. It is an honor and a blessing to be here. Probably the place I'd want to start, knowing that I'm on the call with some good friends, Dr. Jakutu, Dr. Thea James, and our other panelists, and some of you joining the line, our friends, mentors, advisors to me in the work that I do. I represent 50 community health centers across Massachusetts, serving over 1 million patients out of 285 practice sites. We are entities born out of the civil rights movement as phenomenal leaders like Jack Geiger and Count Gibson and Dr. John Hatch and others, Black physicians across this country came together and built off of this model that they saw, that Jack Geiger saw in South Africa, of bringing healthcare to community, and launched this movement aligned with and in concert with the civil rights movement in 1964. I had the honor of hosting one of the architects of this movement, Dr. John Hatch, just last year this time. And Dr. Hatch sat with me. We did a one-on-one conversation. And one of the things I thought was compelling about his story is that when he was in Boston at the doing the public health work in Boston, and really being a part of this movement of civil rights and health equity, he was asked to go down to Mount Bayou, Mississippi, to the Delta to launch what would become the second health center in the country. And he said, Michael, you read it in the book, but I want to share with you that when I landed on the ground in Mount Bayou, abject poverty is what they describe it as. I come out of housing developments and housing projects. I grew up poor, single mom, inner city housing development. He described abject poverty, right? Where homes are in great disrepair, where people don't have access to care. We're talking about Mississippi. He said, Michael, when I got down there, the work was picking cotton in the 1960s. So what I did was I didn't let people know who I was, and I was there to kind of explore the launch of a community health center. I started with putting myself on the ground and getting out in the fields with those Black women that pick cotton. And if you ever read Out in the Rural, and you're on the call with several professors, including me, I give out homework. So I'm gonna apologize now that you didn't get on this call to get homework, but I give out homework. Read the book Out in the Rural, Google it. And I'll say, go to YouTube, and there's a 22-minute video called Out in the Rural. I need you to watch that. It'll give context for the work that I would do, and quite frankly, much of what you'll hear today in this conversation around trust. What he did was he got into the fields and helped pick cotton. And he talked about how his hands were brutalized every day at the end of the day with these Black women who had picked many, many more bales of cotton than he did. And he couldn't understand how those women did it day in and day out. And he had sort of swooped in from Boston to Mississippi and was sort of contributing to this work just so he could get grounded in the community and understand them, and that they could have trust in him way before he actually started asking them to work with him around building a healthcare infrastructure in Mount Bayou, Mississippi. I want to lead with that because I think that model, the sacrifice that he made to build authentic relationships to gain trust. Next year, we'll be celebrating the 60th year since Dr. King went to Chicago to speak at the Medical Committee for Civil Rights, the Medical Committee for Human Rights. And he went to Chicago while he was working across the country to integrate schools and desegregate schools and integrate lunch counters. And traveling the nation just 2 years before his assassination, coming off the heels of the Civil Rights Act and the Voting Rights Act, which were all being implemented, and the challenges that came with the implementation of those new laws. He went to Chicago because he understood that healthcare also was a place that we needed to address the segregation within healthcare systems, the fact that many of our hospitals in this country were segregated through the 1960s. Now, many of you, if you work in public health, healthcare, if you're a follower of civil rights, if you know who know and follow Dr. King's teaching, you've heard the quote, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. I'll repeat it because it bears, it's worth repeating. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And I have the privilege of, when I travel the country and speak at conferences, I'm right now in DC, 1,400 health centers serve patients out of 14,000 practice sites are all here in DC. We'll be on the Hill tomorrow visiting our congressional offices. They're blue, they're red, they're rural, they're urban, and that's, of course, I mean Democrat, Republican, and patients are being served. But I want to correct the quote. That's actually not what Dr. King said, but I think it's pertinent for today's conversation. He said, "We are concerned about the use of federal funds to support this most notorious expression of segregation. Of all the forms of inequality, injustice in health," note that I didn't say health care, the broader understanding of health, "is the most shocking and the most inhuman." I didn't say inhumane, quote, "because it often results in physical death. I see no alternative to direct action and creative nonviolence to raise the conscience of the nation." That's really what I'm talking about as I sort of swoop in with my comments today. We're at a critical juncture, and I think the model of the health center movement is an example about how you build trust. Building trust requires authenticity. It requires a recognition of the injustice. When we do this work, Jack Geiger, and when you watch the Out in the Rural documentary, he says, as he's in Mount Bayou in the Delta, "I don't know if the public officials care about dead Black babies." Imagine how controversial that was when this documentary was made. And now imagine how controversial that would be today to say that in this moment we're in. But the reality is, and I get to do a presentation across the country in health inequities. I can go down and I start my classes off, both my law school class and my Suffolk class. I overwhelm people with health disparities. I want you to know how Black women are surviving and not surviving breast cancer, whereas women in general are surviving breast cancer at rates that we're celebrating, but not Black women. I want to talk to you in a classroom or on this call about Black men in cancer or diabetes or heart disease, and the lack of research on the conditions that are impacting Black and brown people, sickle cell. I want to talk to you about our wealth gap, the poverty rates, how we're unbanked, unhoused, the social determinants, the upstream, the 80% that's driving our health status. I want to talk about unequal treatment. I want to overwhelm you in the first day of class with the fact that Rebecca Lee Crumpler, as Dr. Jakutu and Dr. James know me to quote her, "They seem to forget there's a cause for every ailment, and it may be in their power to remove it." Her sage advice in 1864, the first African-American female physician here in Boston and New England who served during Reconstruction after slavery. I'm mention all of this because I think recognizing how we got here is a critical part. Now, I know we're banning books, not we, not you on this call, but books are being banned. I know that history apparently doesn't matter, at least authentic history may not matter. But I'm not here to talk about that history. I'm talking about true American history, US history, public health history. And the reality is they seem to forget there's a cause for every ailment, and it may be in their power. Hospitals were segregated. People were being experimented on. People did not have equal access to care. They lived in communities that were environmentally unsafe then and now. We thought that we were responding to disease, and in fact, we were weathered to the condition. Channeling Dr. Geronimus in 1990 and her research around fertility of Black women. We need to now have the recognition when we walk into communities that, one, I want to listen to you. Nothing about us without us, born out of the HIV/AIDS movement, requires that we go in, we ask authentic questions. I'm not talking the performative thing that some people do, and they say, "Oh, we want community feedback." And then they come in and they sort of just ask some questions. They check the box that they did community engagement, and then they actually don't apply it. That's not what I'm talking about. I'm actually talking and going in and asking my mother, who grew up in the projects, what do you need? What did you experience? Did you have equal access to care? What did that provider say to you when you told them that you had a pain? Did they believe you? Asking and engaging communities authentically, and then raising their consciousness about the history and the context for their condition. I want you to know about Tuskegee syphilis because I don't want to gaslight you. There was a time you were experimented on, that your pain was ignored, that you were denied access. It's not just because you didn't eat right, you didn't pull your pants up, you lived in poor communities, you didn't. We got to provide some context for people so that they can then be empowered to say, now I want to be the captain of my own ship. I want to lead to a better health outcome. I want to be able to engage my provider in a way to get the best results. I want to ask the right questions. I want to know what my rights are when I walk in to be cared for. I want to know what I deserve in terms of that 80%. I want good housing and good food and healthy food. I want to know that I don't have to have racism and trauma. Yes, I'm saying it as we sit here at 120 in an environment where they say, take the words down. Don't say health equity. Don't say equity. Don't say racial justice. I will not stop saying it. The reality is history matters. And I can overwhelm you with Dr. King quotes that remind us about courage in this moment. So I say this as I sort of wind up my remarks for today. If not you, then who? And if not now, then when? You as public health professionals, as you as leaders, are obligated to get to the truth, to understand, to engage communities, to build that trust, and then to turn that data around, those statistics that I share in my first 1 or 2 days of classes, whether it's law school or public health course. I want you to feel a responsibility to do something, to meet the moment, to challenge systems, to show up, to be authentic. I'll lend it on this. I jokingly say all the time, and again, these are bad words today, that I'm glad so many people are woke and others are waking up, but some of us are insomniacs. I am on this call today with some insomniacs who don't go to sleep because you'll see it in your patients, you'll see it in your data, you'll see it as you walk through communities, and I'm just honored and humbled to be here for the conversation. Thank you.
Mr. Curry, Michael, thank you so much. I really appreciate your voice in this discussion. And as usual, you took us to church. Thank you very much.
You-
Dr. Jackson, you're up.
Can you all hear me?
Can hear you fine. Thank you. And the screen looks great. Thank
All
you.
righty. What's up, good people? I appreciate the invite. You all will see my face once we get to the collective conversation. Uh, I live in Kentucky currently, and I'm from St. Louis. I always like to give that context for a number of reasons. But again, appreciate the invite. And I'm going to start by mentioning the prompt that you all gave us as we entered this conversation today. So you all asked us to reflect on trust as it relates to community organizations and how it informs public health practice. And so as I reflected on this prompt, I centered the word trust. And so that led me to think about experiences that rupture trust, that minimize trust, and that prevent trust from occurring altogether. And so if we consider social ecology, right, that expands the lens that impacts where we place our trust, right? So, for example, we contend with a lot of information as we navigate our daily lives. Interpersonally, right? Somebody might lie to us or tell us one thing in a personal relationship, for example, and then we get access to their phone, and it's like, what is this? What are those? You know, or disinformation campaigns like we're seeing and have been seeing over the past 4 years with critical race theory and with diversity, equity, and inclusion, or even misinformation that has, been a long-standing point of contention around things like vaccines. And then we also contend with systems, right? Systems that deny our abilities to meet our basic needs, our human rights, and many of these rights that are delineated in declarations and constitutions across local and global levels. And, as humans, right, our orientation in assessing these things is, was this experience accidental or was this purposely done? Is this a one-time thing or is this something that's patternistic, right? And so when our experiences are immersed in violations, that can provoke trauma. And so if we look at this non-exhaustive wheel of systems that we navigate, or that navigate us on a daily basis, it's like, what is our assessment of these systems? Are they good for us? Are they bad for us? Are they humanizing us? Are they terrorizing us? And so, based on your identities, based on the intersections of those identities that we carry, you and your communities will have different answers in how you experience, for example, systems of education or health or politics, justice, etc. And so we know that when isms such as sexism, racism, classism, nationalism are institutionalized within these spaces, then we see the fruits of cultural and structural violence being sustained. And so, bam, here we go with the trust issues. And so let's view a couple of what we might render as trust issues. Bloody Sunday. So we are a month away from the 60th anniversary of Bloody Sunday in Selma, Alabama. And so what this was, many of you I'm sure are aware, this was an attempt to march from Selma to Montgomery to engage in the political discourse and demonstration and direct action to make voting rights demands, right? Because despite the Civil Rights Act being passed a year before, we know that, and the Civil Rights Act obviously addressed discrimination, uh, voting rights were still being infringed upon, right? So we know that in Selma, Black people were over 50% of the population, but less than 2% of registered voters. And that was obviously done intentionally. And so when we ask why, then, why is there historically and still contemporarily so much resistance to people having access to the right to vote? Well, we know that political power leverages control over systems and economic landscapes, right? So we're talking about resource allocation that affirms our human rights. We're talking about oversight for the protection of our rights. And we also talking about accountability to redress any rights that might be violated. And so political power can significantly impact all of those things. And it's clearly visible right now with the current administration and the executive orders that are coming down the pipeline that are infringing upon people's civil and human rights. And so what does this represent, though, right? This represents trauma. This represents a lack of trust in the political systems because in 2025, we still have voting right fights that are going on across the United States. Here we have another example, right, from the academic literature. So here we have evidence of violations within the education system, right? So we know across the country, many communities, Black young people, Latinx young people, especially Black boys, right, being suspended and expelled at significantly higher rates. And we're talking about longitudinal, not nothing acute. So this is again, this is not a one-time thing. This is something this has been identified as a pattern, and not just in one community, but in communities across the United States of America, where there are inequities in the ways in which certain communities of color, especially Black communities, are disciplined within the school system. And here we are with another example, right? So we can go back to 2014, Ferguson uprising. We can come to Louisville, where I currently reside, Breonna Taylor uprising, and a number of uprisings in between, right? And we can look to federal investigative evidence that has consistently identified the unlawful discrimination against Black people and other people of color in policing enforcement activities. And also things, such as discrimination against people with behavioral health disabilities, etc. But again, right, these are the systems that we pay for, right? We pay these systems to care for us. We pay these systems to protect us. And so, based on our identities, our positionalities in society, we consistently have disparate outcomes as we engage with these systems. And so then what does it mean for us as we translate, right, these systems that we navigate that exist right within our community space, and then also community organizations that many of us engage with, whether it's for partnership purposes, whether it's for service provision perspectives, whatever it's for, right? We're all in this ecosystem. And how do we work towards building trust in ways that allow us to navigate society in more healthy ways? And so, don't expect you to break your neck to read this will, but the citation is down there in case you want to check it out. So this is recent because it's relevant because it's a recent study that centered and explored the necessities of trust building between community organizations and service populations. So I do want to throw a caveat. The research sample did include the organizational leaders. So the voices were translated from the community through organizational leaders. But I do want to note that. Nevertheless, this study was situated within trauma-informed capacity building intervention in LA County, right, which we know is the largest county in America. And so some might not be familiar with these general findings, but I know many of you are. And essentially what this is illustrating is the collaborative nature, the participatory nature, the empowerment oriented nature that communities want to see as they engage with formal structures, institutions, organizations. And so many people on the call might, be oriented to approaches such as community-based participatory approaches, YPAR, right? So youth participatory action research, social justice, youth development, community-based collaborative action research. We can go on as it relates to naming the different models and approaches that we have available to us to guide how we engage equitably with ourselves internally as organizations, but also with the people we serve. And so now more than ever, as we talk about how this is relevant to public health, is now more than ever, these models must be centered in the work that we do in the classrooms as we engage with our students. What I want to particularly call out, though that's not necessarily explicit on this slide, is the directly impacted leadership, right? So as we talk about what's needed to build trust within organizations, is there directly impacted leadership and also directly impacted employment. Because to what extent do you have the experiences that have shaped your lens for the type of action that we need in communities to fight the pillars of white supremacy, right? Uh, so where do you stand? Where do you, your organizational leadership, and where does your history of action stand as it relates to building political power in Black community? Where do you all stand as it relates to reparations for Black people? Where do you stand as it relates to predatory, brutal policing, wage and wealth gaps, the need for trauma-informed, healing-centered care, and conflict transformation, and also socio-political education, right? Are these things uh, something that have been historically lifted up, valued, and facilitated within your organizational spaces and relationships that you have with communities or not? And if not, again, we're currently in an acute state of upheaval, and these are the things that we need to be centering in our public health practice and also in our public health education and training. Also key is an ecosystem of organizations that act as protective intermediaries for those of us who are more susceptible to cultural and structural violence. such as racism and white supremacy in society. Because again, as we've just reviewed, there are within literally every system, there are histories of the cultural and structural violence that's killing us on a daily basis. And so if we have organizations that understand that, they value that, they censor that, and they're action oriented as it relates to how they protect us, as we have to navigate and engage with these larger systems, right? The more that they can do that, the better, from a utility perspective. And they also must act in unison. So are they acting together? We know that we, exist in a competitive environment, but also how are we intentionally building ecosystems that allow us to come together and act in solidarity. Two organizations quickly I want to shout out that I collaborate with, and they're also Black led, and these people are my friends and colleagues. Cities United. They're a national organization that works on creating safer and healthy communities through violence prevention and a number of other constructs in our communities. Anthony Smith is the executive director. Do a lot of capacity building across the nation, a lot of trainings, etc. So hit them up, look into what they can provide potentially for you in your communities. And then the other is Cure Violence Global, led by Dr. Monique Williams, again focused on violence, but not the consistent messaging of the interpersonal violence, but again moving on up ecology. So what does it look like for us to disrupt dismantle some of these roots of structural and cultural violence? And so she's been able to bring that lens to the organization over the past couple of years and help lead that work. And finally, I want to end with this slide, right? So again, when we're talking about leading with direct impact, there's the Black Panthers, right? They don't get enough credit for the ways in which that they were protecting Black community and fighting for social services for people who otherwise were facing the atrocities of society based on race, based on gender, based on geography. And so when we look at, what some of the things that they did, their 10-point program, and providing groceries, right? Hey, come to this conference of survival, and we're gonna not just feed you here, but we're gonna provide 10,000 bags of groceries. These are some of the illustrations of what it looks like to build trust and actually take care of community. And I do want to say, but our good sister Sada Shakur, as she stated, it is our duty to fight for our freedom. It is our duty to win. We must love each other and support each other. We have nothing to lose but our change. We have to hold that near and dear right now. We must illustrate that as we move forward.
Dr. Jackson, thank you very much for your robust conversation. The presentation that you provided brought a lot of different data and resources in that, so thank you so much. Next, we move to Dr. James.
Thank you, Craig, and thank you for Boston University School of Public Health. Thank you for making it possible, for inviting me to be here today and share this time with the audience and also with my esteemed colleagues. Second. Are you able to see
Green
that?
and your voice comes through loud and clear.
Okay, all right. I'm just trying to order these slides around. Oh boy. Sorry. 1 second. Okay. Am I sharing?
You are. Yep.
Okay. So I guess I just want to start off by, just noting that Boston Medical Center has always been a hospital that was sort of, designated to enable its patients to thrive, and certainly to do better than they were. It was the first municipal hospital in the city and in many cities in our country. And what you see here is it opened in 1864. That is what you see there on the left-hand side, and on the right-hand side, is what an ambulance used to look like. But I am showing this because its intentionality and its purpose for being has always been the same. It has not really changed very much. It's changed, definitely has changed, but in terms of its intentionality. This right here is sort of a tent ward, because it was for soldiers who were coming back from the Spanish-American War in 1898. Even then, there was not enough space. And so we've always, been developing various different types of care models to address the challenges that our patients have. And this here is just an example, everything here from data around children who aren't growing well, legal issues, community violence issues from the perspective of, again, enabling transformation and thriving among its victims, helping people with economic mobility, doing people's taxes to make sure they are able to capture earned income tax credit. And we also have a really keen insight into the fact that, one of the main reasons why our patients don't thrive often is an economic issue. So, and also stability, things like housing, which can really change people's outcomes and also helps with cost. And so it's honestly a much better health model for outcomes, and also a better business model for the healthcare system. It also enables people, when they're thriving, to be able to contribute to the entire aggregate economy. And so everyone literally wins. And then we were challenged, I would say, back in, it's been a while since I've looked at this slide here and talked about the impact that the pandemic actually had on us as a hospital. A majority of our patients are government insured, with almost 2/3 of them being Medicaid. And we were one of the first hospitals, I would say, to tilt when the pandemic occurred, because a majority of the patients who were not doing well, and having higher rates of death from COVID-19 were our patients. This is another example of that that was published in the Boston Globe. And this is our catchment area geographically in the blue. These are where most of our patients come from. And the reason I'm, by the way, giving this as an example is to show you what community engagement looks like to create trust from the community to the hospital. Because many community members, many people in communities don't trust hospitals and don't trust doctors and that type of thing. And this was an example where we actually had to have great intentionality to gain trust from our patients. Every day, given that so many of our patients were involved and were doing worse than everyone else, we had this weekly data report. We actually also, which I'll show you in a couple minutes, we also had a 47-page 24/7 dashboard where we were watching all kinds of things. And basically we were collecting these data to take a look at, what were the critical pieces that sort of highlighted people who were doing worse, and also looking at people who didn't do quite as badly, and what those indicators were. And pretty soon, though, a vaccine came out. And when the vaccines came out, it was a good thing that we now had a vaccine in some ways. But the problem was that where the initial vaccine sites were set up was not aligned with where the people were doing worse in the city. And we were able to highlight that here, as you can see, where the vaccination sites were, but where the populations who were having the worst outcomes were living. So it didn't match up. So we knew that we had to, get working, and we had to think about what this was going to be like. I would say it was one of those times where people in strategy and operations, everybody got involved, analytics, pharmacy, everybody, community engagement. It wasn't just the infectious disease people who were definitely involved, but
Yeah.
all of them were actually walking out into the community. Strategy representatives were out there in the community, engaging with community leaders that were brought to us by our Vice President of Community Engagement, and who was newly here at the Boston Medical Center, Trina Martin. And she introduced us to a lot of clergy at the various different churches and other people around town. And it was one of those things where when our team was engaging with the leaders in the community, it was to ask them, where should these sites be? What should they look like? What should they feel like? What should the operations be? What should the flow be? And everybody was actually working together. And it really came together in a really great way. We had another problem, though. Actually, we had two problems. We had an access problem, but the second problem was hesitancy. We had data that showed many people in the community were not too willing to take the vaccine. And we knew that was a problem we were going to have to address, but without thinking that, many of our employees also work and live in the community. The same thing was happening in our hospital in terms of, who was willing to take the vaccine and who was not willing. So, we had to address it on both sides, internally as well as externally. And a lot of thought went into that. One of the things that we did was to host Zooms where we sort of really stacked the deck, for lack of a better word. I mean, in terms of the hesitancy problem, we had infectious disease doctors and pharmacists actually on the Zooms to educate and answer all the questions that community members had about the vaccine. And we were actually asking the community members as well as the leaders, where should these sites be? What should they look like? What should they feel like? What would make them, most efficient and convenient for them? And so this slide just represents an example of some of the, strategies that we used and tactics that we used to try to get people less hesitant. There was a slide I was going to put in here that I left out, but there was an article that talked about, it said something like, essentially, I too had a bit of hesitancy about the vaccine, and not because I didn't understand the science, and not because it didn't, make sense. I'm not so sure it was quite tangible, but I said it out loud one day, and then I got on the other side of it and once I got on the other side of it, I was asked to publicly share, and let people know what I was feeling and how I got on the other side of it. And literally what got me on the other side was I started to think about people who could not work anymore, people who had lost their livelihood, people who, couldn't pay for where they were living, having food. And I said to myself, if in fact this is really something that will be effective and will turn things around for people, this is the least that I could do. And I could not live with people not being able to thrive and people suffering in that way. And so, that I shared it with everyone when it happened. So ABC News actually came to Morningside Church, where Bishop Borders is, and they talked to many people there. They talked to all of us. They looked at the operations there, and it was a really, really, really great operation. It was a great decision, and it led to ultimately all of these sites that you see here around the city. Some of them, not all of them were churches. Some of them were auditoriums, health centers, and YMCA and that type of thing. But it really, really helped. And we also had these. This is an example of the 47-page dashboard that we looked at every day, able to see what was happening at every single site at any time. And it was pretty dynamic because we made changes based upon what these data showed us every single day. We knew who was getting vaccinated, where, demographically. We also knew who was not getting vaccinated by neighborhood. And we addressed all of those things because we had people walking in the community as well. And ultimately, this is what that kind of like establishing trust and engagement with people in both directions. They informing us, we informing them to the extent that they wanted it. And when you do something like that, we also had help from the state, who gave us as much vaccine as we wanted. You can see what happens when you are intentional about working with community in that way. And you can see here how it increased the rates of vaccination for people who were not necessarily willing to do it in the beginning. And so before, the pandemic occurred, we were doing some other things, in the community and internally. In fact, I would say when the pandemic happened, it made us kind of like look internally to see if we were doing everything we could possibly do to change this decades-old outcomes clinical data, in areas like hypertension and cancer and diabetes and all these sort of like predictable clinical areas, cardiometabolic areas. We were wondering what we could be doing better. And, we did start to take an internal look. And one of the things we did in doing the internal look was working with patients who were part of the data, whose data was being represented there, and asking them to help us interpret it, and asking them to what would have made it better for them and what could make it better for them. And we followed a lot of that. And one of the areas was hypertension in pregnancy. And we, they wanted more convenience around not having to come to the hospital to check their blood pressure. And, so they got remote blood pressure monitors, which they still have to this day. They wanted more education about these diagnoses like hypertension and pregnancy. And so we co-created videos, educational videos with them. And then we did, and I won't go deep into this slide here, but I can tell you that there was a difference in decision-making to take people for C-sections when they had hypertension in pregnancy. And through a lot of work that definitely included interpretation by the patients, by the physicians, the nurses, everyone, we were able to change these data here to this. The decision-making time went down significantly, which translates into better outcomes for people. It really impacts morbidity and potentially mortality. And ultimately, what this led to was some signals that there was an impact happening even on readmission rates, which again translates into cost as well. And so for all that intentionality that we put on this in this work, we have been it's impacted clinical services, behavioral health, determinants of health, and self-management. And I don't want to go through all these data here, but what you can see is that what happens when you address something with intentionality to change it. And a part of the title of this webinar today is action. And one of the things that we had great intentionality around was to design the work we were doing to have transformative outcomes. And we did not want to wait for very long times in terms of what it might take to research these things for, 10, 15 years. We wanted action. We wanted to, and so we designed it for the outcome that we wanted. And that is something that we've learned and using that going forward. I mean, there is a space for research. There's no question here. I'm just showing the difference between what this particular work was designed to do, because we wanted to see some outcomes pretty fast. And all of this happened in about 2 years. And this is another example of things that we did. And again, we've done a lot of type of things around, hiring people, into our healthcare system, which also changes their lives from an economic perspective. We've closed gaps in cancer screenings, all various types of things. As you can see, we've been busy. We've been doing a lot of things, and every single thing that you see here was intentional. And so here's another thing that happened pre and post pandemic. One of the things that, and this came from listening to people in the community, we had invested in a market, which people in Nubian Square said that they wanted. And we were in a business agreement with some owners called Good Food Markets. They were based in Washington, D.C., but when the pandemic happened, they couldn't travel. And they said, we'll find you some local operators. And we found the local operators, two Black men who are both entrepreneurs, and I would say experienced serial entrepreneurs. But they said, we would like to do this, but we are not interested in being operators. They wanted to own the business and the physical space, because again, that's an economic mobility transformation, helps build generational wealth. Those apartments or those units above the store, all retail is on the bottom, on the first floor. Those some were to rent, some were to own. So there was opportunity for people to build wealth there as well. So obviously we had to change the loan agreement. But that meant also that we had to convince several people, other people who were in the capital stack. And so it took us several months, but we did it. And what came out of that was this, Nubian Markets. And, it's in a halal market. It has healthy food. It has a cafe. It has a community space. It has a butchery. It has a grocery store. It's incredible. And, it actually makes a statement and provides an example for what others, can do in that space. And up top is City Fresh Foods, another one of our partners, I would say, who their rent had increased by 150%. And, we partnered with others, the healthcare system and the city, and just to help them because they wanted to purchase a space, to have their own space. And we were able to partner with them and assist them in being able to do that. All of this is intentionality, I would say, around us paying attention to economic mobility, but also building more inclusive, sustainable local economies by hospitals being intentional about how they hire, how they invest, how they procure. And the building you see at the bottom is our mental health center in Brockton, which is all of those things. It was the developers fit that model. The people who live in the community, 60% of the people who work there were hired from there. So it actually helps that economy as well. And it is the only net zero mental health facility in the nation. Carbon net zero. Another example of all of the various different partners that we work with in the community to address pretty much everything that enables people to thrive. And pretty much all of these things help people to get to a place of self-determination and self-sufficiency. But it's the kind of work that we do together with others in the community so that, we can all contribute to it. And then I would say, as we continue to transform, we are, because of all that we've learned, going forward, we're literally rewriting healthcare. And I would say the messaging for that is to the community, once again, clinical excellence, authenticity, partnership, and trust. And I think those first three things there actually lead to the last one, which is trust. And so I'm just going to like show you a quick sort of some examples of that. These are things that you see on the highway when you're driving around. And this is from Boston Medical Center. And, you know, right there, it connects to people. You see this in the train stations. You see these types of this signage, and it talks about like who we are. And I also think it represents authenticity and really connecting with people. And it literally says trustworthy care. Again, doctors who get you. You know, our patients often say that doctors don't listen. You know, they don't pay attention, and they're not wrong. And so, again, we are being intentional about the messaging and what we are doing and the trust that we are trying to create. Once again, this is an orthopedist. This just came out within the last couple of weeks. Top Doctors of Boston, which comes out every single year. I think we might have had like 150 or 60 doctors represented there. Same thing about sickle cell, which is we have the largest number of sickle cell patients here in the city. Same thing, you know, our leaders in sickle cell. I mean, I'm sorry, I hope this is projecting better than what I'm saying, but it might not be. And again, clinical excellence and, you know, being recognized by US News and World Report. Same thing here in neurology and neurosurgery. And all of these things, you know, represent connecting to people and authenticity and trying to establish trust. Together for Hope is a summit or convening that happened last year around addiction and care. It was quite good. It was excellent. And also bringing care to people, you know, versus them having to come to us. This is specifically for new moms, where you have a new mom and, you know, you have to get certain, you know, clinical markers like shots and various different checkups and things like that for babies that are born. And oftentimes it just makes it more of a convenient way of doing that. You know, moms don't have to come here, we can go there. Also, you know, we have broad community engagement. It's not just around here. These are pictures of community engagement, again, led by our community engagement team and our comms team. And this is on Martha's Vineyard right here. And this was around mental health and economic mobility. This is not out of focus. It's actually intentionally blurred because this is actually the 2025 calendar for the community engagement team. And they, as you can see from this, they're quite busy and they're always moving, always on the go. So there is an intentionality around all of it. Thank you. And I hope it was helpful and sort of gave an example of the fact that it actually requires healthcare systems to actually be intentional to create trust, you know, between themselves and patients. It just doesn't happen, and it's not taught in medical school, by the way. So we have to be intentional about it. Thank you.
Thank you so much, Dr. James. I really appreciate you bringing head and heart every single time. Thank you. Dr. Jakutu, you are up next.
Great, thank you so much. It's been wonderful to hear the presentations by the other panelists. Good afternoon, everyone. It's an honor to be here to speak with you. And I want to thank the Boston University School of Public Health. I was invited to give the commencement address a few years ago. And to be quite honest with you, is one of what I would say is one of my true career highlights, to meet such an incredible set of faculty members and all of the students who are being honored with their degrees. And I just truly appreciate all that you do to ensure that the future of public health here locally, that our public health workforce across the city, across the state, is not only secure, but it is bright. So prior to becoming Commissioner of Public Health, I was a health equity researcher, and I still do some research at a small scale. I'm also an infectious disease doctor focused on HIV, prevention, care, and treatment. And it just so happens that one of my research focus areas has been, for most of my career, medical mistrust and its intersection with HIV. And I think that it has had a very significant impact on what we've seen on HIV in our own communities, and looking at non-adherence, low levels of retention and care, uptake of antiretroviral therapy. And it's really made a significant impact. So I have thought about this issue quite extensively. And certainly we saw how it was central to what we observed during the COVID-19 pandemic. And you've heard about that from Dr. James extensively, from all the work that BMC did during that time period, during the height of COVID. But I kind of want us to take a bit of a step back for a moment. And I'm an associate professor of medicine. I teach in classes. I'm professorial in a sense. So I want to talk about the definition of medical mistrust, particularly. And I want to make sure that everybody walks away with a full understanding of what it really is. So medical mistrust is defined as the absence of the belief that providers, public health departments, organizations, researchers, healthcare institutions, the pharmaceutical industry, and really government writ large generally doesn't care for patients or their community's interests. They aren't honest and they aren't transparent. Now, honestly, when I say this, oftentimes I sort of get, oh, wow, that's really deep. Yes, it is very deep. And a large body of qualitative research, what we found is that many people really sort of see this issue of mistrust or distrust, however they want to call it, is really about these entities being duplicitous and underhanded and really contributing directly to poor outcomes. Oftentimes, people will bring up the Tuskegee syphilis study, and I think Michael brought it up, and it's certainly a tragic event in history, but medical mistrust is not about one event. It's not about a couple of events. It's not about history. It's really an adaptive response to chronic, not episodic, issues related to inequity, traumatic experiences, ongoing discrimination, and racism. It's about poor treatment received in emergency departments across our country by people of color, particularly amongst Black individuals, people dying early in their 60s when the rest of the country lives until their upper 70s. It's about long wait times. It's about lower quality of care. It's an ongoing process. And because of all of this, I think it's important for us to understand, because oftentimes we look at medical mistrust and we say that it's the problem of that particular community. What it is it's a well-warranted and rational response to circumstances, to adverse circumstances. And I think that when we try to figure this out sort of within these institutions that are, thought to be lacking in trust, or where medical mistrust is directed towards, we think that, probably the most important asset that these institutions could have or should have is the public's trust. When you think about all of the outcomes that are problematic and related to medical mistrust. And so oftentimes when I talk about medical mistrust, people say, well, so what is it we need to do? What is it we should do? And I think that there were a lot of actions taken, and Dr. James mentioned a number of them, a number of actions taken by institutions to address this issue. And certainly there were, trusted messengers, there were statements about anti-racism, there's training, but then there were real things that people were doing, real things that places like BMC, like the Boston Public Health Commission, like all of our wonderful community health centers were doing. And I just want you to walk away. If you only walk away with one thing from the things that I'm saying, that if you want people to trust you, you have to act, you have to respond, you have to change, you have to do something that the community wants you to do to address the challenges that they face. You have to also shift the decision-making power so that it's them telling you what it is that you're going to do. So these are the things that, if institutions really care and if they truly want to engender trust, they need to do this. And by acting, by responding, by changing, you actually become trustworthy. So I'm going to share a few slides, and I'm going to go through this very quickly. I realize we're running out of time, just to show you how we think about acting at the Boston Public Health Commission, and what does that mean for us in public health, particularly because I realize that most of you are probably students of public health, and many of you may go into public health as you're thinking about your career. So the Boston Public Health Commission, we revamped our mission in the last few years. And I pushed for this to happen because our previous mission, I thought, was rather bland. It didn't speak to communities. It didn't speak to the role that, folks with lived experience play. It didn't speak to the needs to address racism or systemic inequities. So this is our new mission statement, if you haven't seen it before. So work in partnership with communities to protect and promote the health and well-being of all Boston residents, especially those impacted by racism and systemic inequities. And quite frankly, we're all impacted by racism and systemic inequities. So what are we actually doing? Well, let me set the tone by giving you some data, and you can have all these slides because I think they're well worth you reviewing as you're thinking about, what it is that you want to do to act. So here in Boston and across most urban centers across our country, we have problems. And one of those problems is related to life expectancy and early death. And I could talk about some of the other problems, including infant mortality, maternal health disparities, severe maternal morbidity. But let's just stick to life expectancy and particularly, like I said, early death. So here in Boston, you should have seen this data before. We know that there is a census tract in Back Bay where life expectancy is really high. It's 92 years, and most of these people are white, and they're higher income. And then a lot of people have repeated the data that I've put out there in the media, my team has talked about, that if you compare these data to data that we analyze in Roxbury, which is a primarily Black and brown neighborhood where it's lower income, fewer people have college degrees. The difference in life expectancy is approximately 23 years. And like I said, many people have repeated this data and have sort of focused in on Roxbury as being, the one area in Boston that's very different from this area, say in Back Bay. The reality is that we have challenges all over the city of Boston. And if you look at Dorchester, here is a census tract where life expectancy is 20 years lower than in Back Bay. And again, you sort of see a similar, a little bit of a different dynamic here, but literally you have sort of lower income, you have individuals who are dying earlier. And here you look at Mattapan, you have folks who are also, dying earlier than folks in Back Bay. And you see this throughout our city. You also see it in Jamaica Plain, you see it in Alston Brighton and other census tracts throughout the city. And when you take a look at this citywide and you kind of look at life expectancy across our residents, more than 700,000 individuals, and you break this down by race, what you see here in that lower blue line, our life expectancy is 75.4 amongst Black individuals, which is more than 12 years lower than it is amongst Asian Pacific Islander individuals. And I make that point because oftentimes we compare ourselves to white communities, and we say Black-white differences, but I think we just have to look at the entire range of races, ethnicities, and see where the gaps are, where the challenges are, and there are clear gaps and challenges. So I think when you see these data, you may say to yourself, well, wait a second, what exactly is going on here, particularly if you look at Black individuals, because in the data that we have, we basically see that premature mortality, so death before the age of 65 years, has increased about 40% amongst Black individuals in the Boston area. And the question is, what are they actually dying from? So number one is drug overdose. And we've seen an increase in drug overdoses, not just opioid overdoses, but oftentimes mixed substance use disorder, particularly amongst Black individuals. Second, preventable cancers. And third, heart disease or cardiometabolic disease in its entirety. So these are really the top three causes of premature death. And specifically, I want to focus in, again, on Black individuals, because I do think it's important to kind of really be intentional, as Dr. James mentioned. And to be intentional, you have to think about where the problem really lies. And you see here that it's really Black men who have this significantly lower life expectancy than other folks in Boston. So I mentioned overall life expectancy in Boston is around 81 years of age, or at least you saw that in the previous chart. So you see it's 70 years, a little over 70 years amongst Black men. And really we're talking about the same top three causes, just in different order, Black men versus Black women. Now, all of us should know this because I think that most of us on this call are students of public health. So we know that health outcomes like life expectancy and premature mortality aren't necessarily dependent upon what happens within the walls of healthcare institutions. I think it's wonderful that our healthcare institutions do work in the community, do amazing work that's already been described, but we really have to focus in on the fact that we're talking about upstream factors. We're talking about structural and social determinants of health. We're talking about conditions within communities. So in 2020, we declared racism a public health crisis. We know that structural racism is a driver in most of our lower income communities of the quality and quantity of the social determinants of health that are at one's disposal. So that's the parks, it's your transportation, it's your housing, it's your social supports that are available specifically within your community. It's the education that that you have access to. And in particular, it's about economic mobility, which interestingly, if you look at the drivers of poor outcomes, socioeconomic status, income, economic mobility, and then further, a bigger sort of impact, wealth and generational wealth are really the factors that are going to impact your lifespan, the quality of life that you live, the rate at which your community dies of premature death, and all of these things that are of such critical importance as we look at communities across our country. Okay, so what do we do about this? Because again, I think most people understand this to be the case, that if we truly want to change things, we have to actually do something. We can't just talk about it. We just can't train about it. We can't just, do things like put out statements about it. We actually have to do something. And so this particular initiative, Live Long and Well, this is Boston's first population health equity agenda. We've issued this. There was a press release last year, and we have a very detailed report talking about each one of these premature causes of mortality and what it is that we as a city are doing about it. What are the upstream, what are the midstream, what are the downstream things? But then we're also talking about the other things that certainly impact quality of life, certainly mental health, older adult health, what it is we're doing about social connections, and then, of course, looking at infant and maternal health, where we continue to have challenges. So the big message here is that we've made a commitment and we have a long-term goal. We will close the gap in life expectancy in Boston by 2035. So how do we get there? Well, there are essential actions that we need to take, and I bet you could guess some of these without me, having this slide here. Well, one is that partners like communities, they need to lead the way. They need to be at the center of all this. They need to be making the decisions. They need to be deciding what interventions are designed, and there need to be shared goals. And this isn't something that's trivial. It's not about having some advisory group. It's not about having some meeting with somebody who says that they're, a key stakeholder in a community. It's about truly investing in communities. It's about truly, in some cases, getting out the way and letting community members actually lead, which I think is a difficult thing for some institutions and for some entities to do, especially if you're talking about investing dollars. It's about focusing upstream, as I mentioned, but we also have to focus downstream. I mean, we have to partner. We have to understand that you need upstream and downstream inputs in order to get good outcomes at the end of the day. It's about leading with data, and that's why I started with the data that I provided to you. It's about investing collaboratively. I think that's important. I think it's something that we're moving closer to here in Boston. I think we could still do much more of that, working together to not just, invest as single institutions, but really work together. It's about thinking about place-based strategies. So that means this word intentional, sort of thinking about where the census tracks, where there's lower life expectancy, and what do we need to do to fix what's happening in those particular census tracts. Amongst those thousands of people who are there, living there, what is it we need to do? Promoting accountability and sustainability are key factors that obviously lead to trust of the people doing the work, as well as trust in our ability to actually create change at the end of the day. We have to be accountable. If we say we're going to do something, then actually doing it. And certainly developing new initiatives. But I do want to emphasize that there are lots of things that we're doing across the city of Boston, but maybe we're not doing them as well as we should be doing them. We need to be strengthening the work that we're actually doing and making sure that it's high quality and actually evaluating it to know where there needs to be change. So that's another thing that we certainly need to invest in. So collaboration and partnership, this particular plan, Live Long and Well, involves community leaders. It involves our departments across the city. It certainly involves our healthcare institutions, particularly our community health centers. And in terms of money, certainly, you can get money from lots of different sources, but bringing in foundations and the private sector is key. So I'll just tell you very briefly about our first, what we hope to be a catalytic investment to get this work going, specifically around promoting economic mobility. We have a partnership with Atrius Health Equity Foundation. This is a multi-sector partnership that involves Boston Community Health Collaborative, of which Boston Medical Center and Dr. James and Michael Curry and lots of folks in the community health center world are involved in. Multi-sector partnership that will essentially focus in on how do we promote economic mobility as an upstream driver of downstream outcomes. Okay, so what people have access to, how they are able to live their lives and maintain, and have resources and have a safety net, that determines how people actually live, their quality of life, as well as their lifespan. We'll do this initially using a $10 million investment, and this is great, but it's only a start. And if you think about, $10 million, it doesn't necessarily go far. So we're certainly looking for other partners and looking for additional funds. So currently we have an RFP that's out for half of that money. So $5 million is out. We're looking for proposals that are led by community members. So again, I'm sticking to this idea of shifting decision-making power, really putting the money where it needs to be, giving it to folks who know how to design solutions to fix the problems in their own communities. This is the proposal. It's due, March 12th. I put this out there because there are probably a lot of people listening, and we certainly want to make sure that people are aware this is something that we're doing, and it's due March 12th. So I'm going to stop there, and I'm hoping that I didn't go too far. Yeah, we still have some time left, and I apologize if I didn't leave us enough time. Sorry, Craig.
Commissioner Adututu, you wonderfully rounded us out with really speaking to the distrust, where it comes from, and how do we move forward, and then bringing us towards a solution-based kind of consideration. So thank you for your presentation, and thank you to all of our panelists for your presentations and for bringing all of who you are to bear. If you would, please, everyone come off on camera. We really don't have much time to go through audience questions. So I'm going to give one example question that I think touches on some of the things that people put in their Q&A. In this environment of growing misinformation and disinformation, misinformation, inadvertent falsehoods being put out there, and disinformation deliberately putting falsehoods out there, what are you doing well, and what do you think you or we could do better to connect with those who think differently than our organizations or our fields?
Hop in.
Sure.
So I'll take us back to 2021 when we saw the surgence of anti-critical race theory bills flying across state legislatures. And so Kentucky wasn't exempt from that. Our legislatures facilitated their own pre-filed versions of those bills that summer. And so when I became aware of that, I began to engage students and employees and communities and organizations across the state of Kentucky and understanding the threats of those bills, right? So it wasn't about critical race theory. It was about banning conversations about race, about religion, about, as they labeled it, sex in the classroom. And so that's when a lot of my organizing around, this mis and disinformation began. And so that continued throughout 22, 23, and also last year. And so moving from the local and the state level, shout out to the University of Maryland, College Park, and also Washington University, I was able to expand the conversation nationally about like, yo, we are literally under siege, and not just in what people traditionally designate as the high risk or the red states, because by that time, last year, some of these bills, these same, quote unquote anti-DEI bills were in Congress. And so part of what, a lot of that movement was, that organizing and mobilizing was for people to translate that critical consciousness of understanding what the bills were actually about into their own advocacy and direct action efforts. So that, those illustrations of their engagement looked like testifying before, our House and Senate committees, to peer education initiatives, to organizing and mobilizing in, their respective and identified communities. Last year, I also partnered with an entity called Success University, and we did community-based popular education sessions, and they were entitled, "What the Fuck is Project 2025?" So we went through all of the sections. Of course, it was abbreviated, it was truncated, but we were ringing an alarm saying, yo, like, this is, if the election goes in a particular way, these are the things that we can expect. How are we prepared to fill in the gaps of, human and civil rights that will be violated? What type of legal measures will be taken? What type of service gap facilitation are we prepared to engage in? And so now that, we're living in, the current administration's actions, part of what I'm leading with a particular community-based organization is some intercultural organizing, because right now what I'm finding is leaders who have, when I'm not say leaders, people in leadership positions, because everybody in a position doesn't necessarily lead. And so, but they've been really comfortable up until this point, right? And so now that, certain resources and assets that they have, had security within over the past, however many decades of their lives, now these things are at stake, right? So I've never seen so many people who have been concerned about their NIH funding or their CDC funding, come to organizing meetings. That's a great thing, right? And so how do we also, in that same space, call people into the fact that before now, you minimize the marginalized justice work, equity work, anti-racism work, and so anti-oppression work. And so now that you're being touched and you're showing up into these spaces, right, that's a source of conflict. And so as we begin to engage in intentional intercultural organizing, these types of issues will arise. And so we'll need to be, we must have the capacity to engage in some of the trauma-informed and healing-centered and conflict transformational organizing, just as well as at the same time we're engaging in the organizing that's against the oppressive forces. So that's some of the work that I'm doing, some from my university seat. Obviously, a lot of that is focused on the education. And then as, my private citizenry work, that's a lot of the organizing and beyond across the state and across the country. So
Thank you, Dr. Jackson. Michael, very quickly, I know we're going to be stopped pretty soon. Can you say briefly how we may be able to build more strong, sustainable, meaningful, powerful coalitions across identities in a way that stands up for the people's health?
Yeah, I think there's a lot of efforts, and you are part of that. Others on this call, Dr. Jakutu and Dr. James, 2.5 years ago, a group of us got together during COVID, really 3 years ago, and all of us were on every task force known to man and woman, talking about how did we end up in this place where some communities were disparately impacted by COVID-19. They were more likely to be infected, hospitalized, and die. And Dr. Jakutu was on the front lines from Boston, really responding to that. And out of that conversation came, we need to do something about the broader issue of health equity and the challenges in public health. And we organized what we call a Health Equity Compact, now a group of over 85 leaders of color who've come together for the last 2 years. We've presented an omnibus bill. For anyone who doesn't know public policy, omnibus means a whole bunch of stuff packed into a piece of legislation that touches workforce development and quality and data and all of the other aspects of trying to deliver on health equity. And we are, as far as I know, and I've traveled the country on this, there is no other model like it in the nation. I've had people call me from London and other countries to say they've never seen it even in other countries. To have people with lived experience, people of color come together and drive the agenda. We are very privileged people on this call and across this country that we're now in positions leading public health departments, hospital systems, health centers, philanthropy, academic institutions. Why not marshal all that brilliance, power, and influence to prioritize health equity in a way that we see the numbers change? I started the conversation, my friend, by saying that we see the numbers, but the numbers aren't moving. We can move the numbers. We can drive the policy. We can collaborate to then with community and amongst each other to really move that needle. So I'm honored and humbled to be part of the folks that are in that number of 85, now 90, driving this movement. And I hope people do what they did with healthcare reform. Tell that, I say, imitate that, model that in Missouri and in Kentucky and in California and in London, because I think we need to take this challenge to eliminate health disparities seriously. And if not us, again, if not us, then who?
Thank you all. I
Craig,
know we have to go, Dr. James, I'm sorry. Thank you, everybody, for this conversation. Dean Stein, you have the last word.
Yeah, no, thank you. Thank you, Mr. Curry, for ending at such a high note. Thank you. Thank you all for being part of this conversation. Thank you to this inspiring group of speakers, to the Activist Lab, to Professor Andrade, and we look forward to seeing you at one of our future public health conversations. The next one is April 1st. So please register and join in. There's a lot of conversation that I hope continues after this one. And have a good afternoon to all of you. Thanks for being part of our